Okay, I think we'll start off the session today. I would like to welcome everyone, wherever you are in the world, to this edition of the joint Pan-American Hemodynamic Collaborative Neonatal Hemodynamics Research Center International Zoom webinar. We have a very exciting session today focused around something that we really have not paid a huge amount of attention to in the field of neonatal hemodynamics, being neonatal septic shock and a much more thoughtful physiologic approach to it. We have kind of an exceptional speaker. We have a very diverse panel from different backgrounds that we will kind of introduce to you after the first session. My first order of the day is to introduce my co-moderator, Dr. Angelica Vasquez. Angelica is actually a very unique and rare person because, as far as I know, she is the only person in the world who has completed a formal neonatal hemodynamics fellowship and formal training in cardiac ICU care. So I don't think there's anybody like you, Angelica, that has done those two specific dedicated years. So we're very happy to have you in our world. She completed her hemodynamics training at the University of Iowa, kind of in 2022, after returning to Columbia University Medical Center in New York City to complete her second year in pediatric cardiac ICU training. Her areas of academic focus include cardiac and cerebral hemodynamics and the use of non-invasive monitoring to optimize the care of premature and critically ill babies. So, Angelica, welcome. We're delighted to have you with us today. Second, I would now like to introduce our speaker today, Dr. Ashraf Kharrat, who is a staff neonatologist in the NICU at Mount Sinai Hospital in Toronto and an assistant professor of pediatrics at the University of Toronto. Ashraf completed, again, her neonatal hemodynamics training in our Toronto program. I can remember, what year was it, Ashraf? It was
2019.
1990. Yeah. So, and Ashraf has been building a very unique focus in the domain of kind of the hemodynamics of septic shock. Her clinical and academic interests really are bridging cardiopulmonary physiology and quality improvement, and specifically within the domain of sepsis and septic shock. She has published some sentinel papers over the last couple of years in this particular domain. And Ashraf, I'm thrilled to have you here today, and this is long overdue to be talking about septic shock here in this domain. So welcome. The floor is yours. Oh, I would just remind everyone while she's getting set up, put your questions in the Q&A session. Also, be careful to keep your phones on mute. Okay. And Angelica, you and I can drop off the cameras now, so Ashraf doesn't have to look at us. Okay.
I wouldn't mind. Thanks, Patrick and Angelica, and thank you all for the invitation to speak today. I'm really excited to be talking about the hemodynamic considerations in neonatal sepsis and septic shock. I'm going to focus more on a clinical and physiological talk rather than an echo-based talk, so hopefully it's more widely applicable. And I'll start off with a case, a pretty typical case. So we have a 24-week infant, a couple weeks old, who had a pretty unremarkable initial antenatal history. And at 26 weeks corrected, develops new apneas, lethargy, and pallor. So a full septic workup is done and clocks and tobramycin are started. 4 hours after the septic workup is initiated, here are some key clinical parameters. So the child's tachycardic, they're starting to develop some hypotension. The urine output seems to be okay. The gas is a mixed metabolic and respiratory acidosis gas. Lactate's starting to get a little bit elevated, and the glucose is a bit high. A repeat set of vitals, or 6 hours later, this has progressed to more significant tachycardia, more profound hypotension. The urine output has dropped, the gas has worsened, and both the lactate and glucose have gotten worse. And this is a pretty common scenario of the type of thing that we would see in the NICU. So I'm going to talk a bit about the underlying pathophysiology of what might cause this clinical picture, what we need to think about from a hemodynamic perspective, and how we can potentially treat this child. So as we all know, our preterm infants are at high risk for sepsis for multiple reasons: underdeveloped immune system, the fact that they've got lots of tubes and lines and procedures, And they're all colonized with bacteria, which is a normal thing, but somehow that bacteria enters the bloodstream. And when doing that, it goes from when the inflammatory response is then ensued, it goes from infection to sepsis. And the sepsis is really this inflammatory response that occurs at the endothelial level that results in release of multiple active molecules that cause the secondary clinical picture after the infection happens. So we see the clinical effects of this, but I'm going to break it down to a bit of a more microvascular level. And this is really important to understand actually the hemodynamic phenotype, is everything is happening, within that inflammatory response and at the endothelial level. So when the pathogen enters the bloodstream, a pro-inflammatory response is initiated. This induces release of complement. There's a pro-coagulant state that happens, and local endothelial vasoactive substances are released. This is all part of the immune response to try to fight off this pathogen, fungal, bacterial, viral, and then try to basically contain it and get rid of it. The body also has a simultaneous, or should have a simultaneous, anti-inflammatory response to basically prevent this hyperinflammation or excessive inflammation, which can be destructive. And either if you have too much of a pro-inflammatory response or insufficient anti-inflammatory response, you basically have lack of containment and destruction of the endothelial layer, which causes the clinical or the macro picture of what we see. So we will see a patient that becomes really, really sick. They might develop systemic inflammatory response syndrome. They might be hypotensive, hypoxic, and acidotic. And then this will result or comes a part of organ dysfunction. And this is a patient that initially, this is what we see clinically from the patient becoming unwell with their pathogen. Maybe this is the time that we do the septic workup, to the child that's now requiring multiple interventions in order to basically maintain systemic blood flow, organ perfusion, and prevent significant morbidity and mortality. So this complex interplay of various molecules and pathways that are happening at the endothelial level is really important to understand, because it gives us the clinical phenotype that we see. So we have the simultaneous release of inflammatory molecules, vasoactive substances, and that gives us this, typical warm type picture. And at the same time, we have a catecholamine release that causes the catecholamine side effects of a cold type picture. And this complex interplay, or the relative balance between these two, is what gives us the clinical phenotype of what we call warm shock and cold shock. And this is the classic hemodynamic dichotomous categorization that we've used historically. It's not just us, peds and adults have used this. And this is only a starting point, so of what is actually going on from an underlying hemodynamic dysfunction perspective. I'm going to start with explaining this, because this is at the very least a good starting point for understanding the underlying hemodynamic phenotype. So warm shock is essentially a profound low systemic vascular resistance state. This is a vasodilatory shock. So because you have significant vasodilation at multiple organ levels, you will get a child with warm extremities, flash cap refill time, bounding pulses, and then hypotension from the extreme vasodilation. Cold shock is the converse or the opposite picture, which is defined by a high systemic vascular resistance state. This child presents with cool extremities, a delayed cap refill time, diminished peripheral pulses, and initially the blood pressure might be normal or even high, indicating significant systemic vasoconstriction, although that can change to hypotension at a later stage. I'll talk more about the physiology of how that happens. We have this type of dichotomous categorization has been better described in older populations. Adults seem to be present more as a warm shock type of picture. So they have reduced systemic vascular resistance, elevated cardiac output. These are only a few of the many, many references that describe this physiology. And this is why primary vasopressors are used for first-line therapy for adults per the Surviving Sepsis campaign. Children, particularly out of hospital or community sepsis, tends to present in a non-hyperdynamic or low flow state with reduced cardiac output and increased systemic vascular resistance. So the opposite type of picture, more like cold shock. And in neonates, initially is described as a variable presentation. And if we look back, 10 plus years in the literature, there's not a lot to guide what the hemodynamic phenotypes are among neonates with sepsis and septic shock. There's just some small case reports defining this. But more and more, and especially as we're having echo-based studies that are actually looking at the underlying cardiac physiology in infants with sepsis and septic shock, it's become much more clear that this is primarily a low a low systemic vascular resistance state, although this can be variable depending on a couple things. Now, preterm neonates have the additional consideration of the fact that their hearts, their vascular system, their neuroendocrine system is not the same as even term infants, certainly not the same as peds and adults. And this consideration can alter the hemodynamic phenotype and also makes us have to think about them a little bit differently in terms of how they will respond to their sepsis and what their reserve is in septic shock. So for example, preterm neonates have diminished cardiac myocytes, functional cardiac mass. They have more stiffer hearts with less compliance. They've got the presence of shunts, which can alter blood flow. And they just don't tolerate altered load states, preload and afterload the same way as a term baby might. And they have diminished vascular reserve, higher susceptibility to endothelial injury. They have less circulating neuroendocrine response to stress response to high stress states like sepsis. And also what they have can get depleted really quickly with minimal repletion. And we see this quite commonly clinically. We also can see there's considerations of non-hemodynamic organs, so like the lungs and the heart, that they're different in preterm neonates compared to term infants. So they had increased baseline renal resistance, decreased functional renal tissue, underlying baseline lung disease, depending on how prem you are and how sick your lungs are. These things will contribute to the overall clinical picture. And they make it, they give us a unique challenge that we have to think about when we manage preterm infants with sepsis. And then finally, the pathogen can actually play a role in the hemodynamic response. These are just a couple of case reports indicating this. Certainly, we've seen a lot of this clinically, is that certain pathogens may tend to present more like cold shock, others like warm shock. So that, although we don't know that at the time that the baby has had their septic workup, we don't know what pathogen they're growing, but it's interesting that some pathogens will cause certain pictures. So all of that introductory kind of discussion was to indicate that there are a lot of factors at play when it comes to what the overall hemodynamic phenotype is, that these factors are dynamic. They're not the same. Something can happen, then can be depleted, and then another thing happens. So what's really important here is that we, first of all, can understand the full spectrum of hemodynamic disturbances that can occur in preterm and in neonatal sepsis. But more importantly, from a clinical perspective, is these children need multiple reassessments. This isn't a baby that gets a septic workup and you kind of tell the nurse, call me if anything changes. These babies need multiple reassessments from multiple people to basically be quick to pick up any changes in underlying physiology so you can address the hemodynamic disturbances earlier rather than later. Okay, so I'm going to talk a bit more now about how do we actually assess these babies. Where can we start? Well, these children, depending on what your unit practices are for routine vital signs, certainly need more monitoring once you've decided that this child has had an infection. Your time zero starts when you have performed a septic workup. Obviously, the child did not become infected at the time of the septic workup. That's only when we have decided that the clinical symptoms are high enough that they're out of keeping with what we think is regular prematurity. So the infection would have actually happened sometime before, probably hours before. So the process is still rapidly evolving, which means we really need to be on their monitoring. These vital signs, so if your unit, for example, does blood pressure Q shift, you need to increase the frequency of blood pressures being monitored. Most babies are already on continuous heart rate and oxygen monitoring. Some units have advanced monitoring like Hero, but whatever is happening at this point needs to be reviewed much more frequently. Specifically as it pertains to blood pressure, ideally, we don't want to catch the baby when they've already become profoundly hypotensive, and we want to pick up the signs that they have hypotension and evolution by looking at their entire story of their vital signs. So for example, tachycardia is typically a compensatory state, or can be a compensatory mechanism in preterm infants with sepsis. And it can often precede hypotension, especially if you're really following those blood pressures closely. The blood pressure itself, we should not be reporting just in terms of mean blood pressure. We should be looking at all parameters of blood pressure because they actually tell us different things. So the systolic blood pressure tends to reflect cardiac output or the max cardiac impulse. The diastolic blood pressure can reflect the systemic vascular resistance. So when we see blood pressures, and we find often in infants with low systemic vascular resistance state, initially it's actually their diastolic blood pressure that starts to drop before their systolic blood pressure drops as a consequence. And that's an indication that this child is rapidly evolving in this low SVR state, and that we actually have to address them now before they become profoundly hypotensive. Another important thing is if you drop your just your diastolic blood pressure, you might not alter the mean blood pressure that much. And this is another reason why we really should be looking at all parameters of blood pressure simultaneously versus just focusing on the mean blood pressure, which doesn't tell the full story. Or even if the mean blood pressure does drop, looking at the systolic versus diastolic as the cause for why that's dropping can give you a clue as to the underlying pathophysiology. We should be looking at markers of end organ function very consistently throughout the sepsis process. So we typically look at cap refill time, urine output, neurological status, oxygen requirement, thinking of lung as an end organ, and coagulation. These are all routine things that we should be looking at and considering. We can trend biochemical variables that help us with providing more information about end organ function, like gas and lactate. And then some units are using NIRS. In our unit, we actually put NIRS on for patients who develop sepsis or evolving into septic shock as another helper of assessing end organ perfusion. So this is step one, basically, of just monitoring these kids for trying to identify these high-risk kids that will progress into septic shock. So we're going to talk now a bit more about what that septic shock phenotype can look like, and what the underlying underlying cardiovascular physiology is. And hopefully thinking through these, you can still apply these principles to these patients who are quite unwell, even in the absence of having echo availability. So we're going to break this up to the warm shock, cold shock picture again, starting with warm shock, which, as a reminder, is a low systemic vascular resistance state. So that's the starting point. When you have low systemic vascular resistance state, you have profound arterial vasodilation. This will cause increased blood flow going into the venous compartment of the body, which will increase venous capacitance, but it's not actually increasing systemic vascular resistance. The blood sort of sits within that venous pool. So you have, not systemic vascular resistance, systemic venous return. You actually have less systemic venous return going back into the right side of the heart, which will diminish the right heart preload. This consequently will diminish the left heart preload, and then will impair left ventricular systolic function, which in and of itself will decrease cardiac output and can contribute to shock. And then that process actually will continue, where you have less cardiac output coming out of the left side, less blood going through the arterioles back to the venous system, less blood coming back to the right side, less blood going out of the left side, et cetera, et cetera. And these patients will develop profound shock with organ dysfunction. And these are the sickest of the sick. So for these patients, if we perform an echo, if you have the opportunity to perform an echo, you will see initially what we call a hyperdynamic profile. And essentially what this is the left ventricle beating, trying to increase its ejection fraction to compensate for the systemic vascular resistance. So as the systemic vascular resistance goes down, the body is trying to increase the cardiac output to basically maintain blood pressure. And it's doing this initially until it cannot do it anymore. One of the ways that it does this is by increasing heart rate. The other way is actually an intrinsic increase in the ejection fraction, in the contractility. And when the heart can no longer do this because it's tapped, because it's reached its tachycardia, there's no, at some point tachycardia becomes problematic because it can impede filling time, diastolic time, or because the actual sepsis, either the bug or the inflammation can actually have direct myocardial impacts. At some point, the heart can no longer do this, and then you will actually get a cardiac dysfunction related to sepsis. Hopefully, we have intervened and we have supported this child before we see that cardiac dysfunction picture on echo. Now, the converse state is the high systemic vascular resistance state of cold shock. This is a high afterload state against the left ventricle. So high afterload can impede left ventricular systolic performance, which will decrease stroke volume. That in and of itself will cause low cardiac output and shock. Then the consequence of less blood coming out of the left side is you have higher end diastolic pressures, which will subsequently impede left ventricular filling, and then so on and so forth. The cycle just keeps going. So for these patients, you can still see compensatory tachycardia and the heart is trying to compensate by increasing its contractile force. But because you're quick to get ventricular dysfunction, low cardiac output state from ventricular dysfunction, these children can then develop cardiac output shock from low cardiac output state, just from a slightly different underlying pathophysiology. So you can actually get these clues from what's happening clinically by examining the child, see if they look like warm shock or cold shock, look at your markers of end organ perfusion, and watching the evolution of the child. You don't necessarily need an echo, but it's certainly helpful to help characterize that underlying cardiac physiology. And especially for the profoundly unwell infants, they might not follow this exact pathways necessarily. There might be additional impacts, like we're looking at pulmonary hypertension, impact of shunts, so other things that are happening to the heart that you can't see clinically, but hopefully you can take some of these basic principles and apply them to a clinical, your patient clinically in the absence of echo. What I've just described is basically macrocirculatory issues. One of the big unknowns that we have here in neonatal sepsis is a microcirculatory impact. We don't really have a great way of assessing microcirculation yet at all in general, but certainly in preterm infants. And just to describe a little bit what's happening, at the capillary level is where the gas exchange is happening. Your oxygen is going to the cell and carbon dioxide is coming back to capillary. And that's a really critical area for oxygen delivery. But in sepsis, you get very variable release of vasoactive substances. So you can have some vasodilation at the arterial level, but it's variable depending on which vascular bed you're looking at. Not all vascular beds are the same. In addition, not all vascular beds have the same oxygen need in sepsis. So your adrenals will need more oxygen than your gut in the acute sepsis response. In addition, because of the altered coagulation in sepsis, you can actually get platelet plugging of the capillaries, which will impede blood flow. And the red blood cells are less able to actually go through those capillaries, so are less able to actually give that oxygen that it's carrying to the tissue at the tissue level. So there is certainly a microcirculatory impact from sepsis, which will diminish the oxygen delivery. It's not just at the macro level, at the blood pressure, big vessels, or even at the heart level. So let's talk a bit about therapies. We understand now what the underlying physiology is, what causes the hemodynamic disturbances. So what can we do about this? Well, we typically talk about fluid therapy as your first line therapy, with the widely accepted rationale that the cardiac output is improved, and basically maintaining blood pressure to maintain organ perfusion. But fluid therapy is, for one thing, an interesting concept, because in preterm neonates, we already know that they cannot handle massive changes in fluid or in loading conditions because of the cardiovascular considerations that we talked about earlier. And not every patient is quote unquote fluid responsive. And I think we probably have seen this clinically, where we've given a fluid challenge and nothing has really changed for the patient. And that really depends on, at the time of where the patient is, of when you're giving your fluid, where the patient is on the Frank-Starling curve. So this is the green one here is the Frank-Starling curve. And basically we're looking at what the role is of fluid bolus, depending on where you're at. If you're down here on the highly responsive part of the curve, or the high slope part of the curve, then giving a fluid bolus is significantly, hopefully you can see my mouse, it's significantly going to increase your stroke volume. Stroke volume is the y-axis and preload is the x-axis. So you're going to augment the preload by giving this fluid bolus. And because you're on this high slope part of the curve, this will result in a dramatic increase in stroke volume. This patient will be fluid responsive. Now, if you happen to be on the plateaued part of the curve, giving that same amount of fluid bolus or that same preload augmentation will not result as a big of an increase in stroke volume, therefore not and subsequently cardiac output. This patient does not appear to be fluid responsive. And in the interest of time, I'll skip the Malloch-Phillips curve. So in preterm neonates, there doesn't seem to be any evidence really to guide on which fluid and how much fluid we should use. So most of us use normal saline as first line, but still the question of what volume should we use before starting next line therapy is a big question mark. So I don't have much to comment there, apart from to say, if you have decided that this child requires a fluid challenge for whatever reason, the fluid challenge should be a fluid bolus and should be a challenge. Increasing the TFI or giving fluid over a pump over several hours is not a fluid challenge. It's too long of change in fluid dynamics to actually see a clinical response. It's hard to assess. And the underlying sepsis physiology is still happening in the background. The child might be getting worse. So you've got a lot of factors at play that's happening at the same time. You want to give this fluid quick, check your clinical response, be it blood pressure if you have arterial line, be it tachycardia, and then proceed from there. After fluids, if the child still requires hemodynamic intervention, then your next step is cardiotherapeutics. So just going back to the warm shock picture, and we talked about the low SVR state, this is your primary pathophysiology. This is the primary problem, is you're systemically profoundly vasodilated. So you can give fluids for the reasons we just talked about, but ultimately these children will need a vasopressor. So a vasoconstrictive agent to basically counteract the effects of systemic vasodilation. And if they've proceeded all the way down here where they actually have cardiac dysfunction in their low SVR state, they may also need inotropy as well. So hemodynamic management of kids with low SVR state, fluids, vasopressor, plus or minus inotropy if late. For cold shock, the underlying pathophysiology is a high systemic vascular resistance state. So we have to either counteract that or counteract the big side effects of high SVR. It's kind of tricky to give a vasodilator in the NICU. It's in these babies because you might actually tank their blood pressure and cause secondary problems. So these are a hard medication to use as a first line, but typically, especially once you already have hypotension in high SVR state, that essentially reflects cardiac dysfunction. So these kids will need inotropy as first line. And you can use fluids, again, for a similar reason, but I'd be even more cautious with giving massive volume for fluid resuscitation. These patients, because they're hypotensive, but they're hypotensive because of a cardiac dysfunction problem. So giving them a significant preload changes may worsen their cardiac function. So I tend to be more ginger with their fluids and then proceed to inotropy quicker. And then we don't have a lot of data yet for what is our first line therapy for these medication for these clinical situations. There are some preliminary literature showing that norepinephrine seems to be a really nice vasopressor agent with good hemodynamic response in preterm neonates. More and more units are using norepinephrine first line. And this study looked at or compared epinephrine, and this is alpha dosing epinephrine to dopamine in a cohort of preterm infants with fluid-resistant septic shock. And though they didn't find an overall difference between using dopamine and epinephrine, what's interesting is in this smaller group of infants, when they did a subgroup analysis in less than 30 weeks, they found a higher hemodynamic response to epinephrine than to dopamine, which has been traditionally our longstanding first-line vasopressor. And one potential hypothetical reason why that could be is because dopamine tends to work via two ways: directly on the dopaminergic receptors and through conversion to norepinephrine to work on catecholamine receptors. And this conversion from dopamine to norepinephrine seems to be impaired in the really small preterm neonates. So you're really just getting that effect on dopaminergic receptors versus the very common, very prevalent catecholamine receptors. So there's a physiologic rationale for using a catecholamine with vasopressor properties like norepinephrine as your first line therapy when you need a vasopressor agent. There's also very small work done looking at adjunctive therapies, what we've considered historically adjunctive therapies like vasopressin, which will target additional receptors in neonates with sepsis. So there's potentially a role for vasopressins as an adjunct in catecholamine refractory shock. And then of course, steroids, where there's been really no big dedicated studies looking at the use and utility of steroids in sepsis, but there's again, a physiologic rationale as steroids can help to maintain, first they can help with improving or augmenting the hemodynamic response to catecholamines, to exogenous catecholamines like norepinephrine. But in addition, in patients that are developing what we call capillary leak syndrome, or at that point of destruction of the endothelial layer, then steroids do seem to play a role in maintaining endothelial layer integrity, which can help with preventing or diminishing that progression into systemic inflammatory response syndrome. So there's, again, physiologic rationale, but not any larger studies looking at steroids. And just to mention, we have started a study in Canada. We started this last year. That's that we are the primary site at Sinai, and it's become an international study with representation across the world to hopefully answer one of these questions, which is to look at dopamine versus norepinephrine as first-line vasopressor therapy in infants with late-onset sepsis. So this is, expect some data to come in a few years' time to help answer these big questions. So until that time comes, at the very least, being thoughtful and considerate of what the intended effects and side effects are of each of our therapies is important. And this is a table I cite often from my friend Regan Geisinger, who put this together this really nice perspective of all of our common cardioactive agents that we use. So for example, if you have if you need a first-line vasopressor because you are in a low SVR state, and then you could use both dopamine and norepinephrine. They'll both increase your systemic vascular resistance, but dopamine will also greatly increase your pulmonary vascular resistance, which might already be tenuous in a child with sepsis or septic shock. So if you are unable to tolerate if the baby is unable to tolerate that consequence of further increasing their pulmonary vascular resistance, then choosing dopamine as your first line agent might actually make that baby worse. So just thinking again about what the intended effects and the side effects, if you can tolerate those side effects, then that medication is okay to use in the absence of further data. And we published this last year, but this is basically our management algorithm that we used at Sinai. We developed this locally in Toronto between us and Sunnybrook, our other perinatal center in Toronto. And this is to standardize the monitoring and management of neonatal patients with sepsis. And this is in the spirit of the Surviving Sepsis campaign, knowing that even the pediatric guidelines don't apply to preterm neonates. They really only refer to term neonates, essentially with early onset sepsis. So not the most common burden of illness of sepsis in the NICU. You are welcome to see the algorithm in that paper if you would like, but we found that it's been a nice framework for people to think about sepsis and septic shock in our NICU. So I just want to make a comment on extra cardiovascular considerations that can contribute to the hemodynamic picture. And the first being focusing on the respiratory piece. So I had mentioned earlier that we could look at we could look at lung as an organ function, and we will often use oxygen need as one of the things that we monitor in sepsis, understanding that oxygen need can reflect oxygen delivery, which can be impacted by many things: lung, heart, vascular, microcirculatory, many different components. But what further can complicate the picture in neonates with sepsis is neonatal ARDS. This paper is fantastic. The DeLuca paper is really great to read as a summary or position statement on neonatal ARDS. But essentially what it is the inflammatory response affecting oxygen delivery from a lung perspective by causing interstitial edema and destruction of the endogenous surfactant layer, which can sort of progress and further the inflammatory response within the lung. And this can cause an oxygenation failure issue of the lung separate from the hemodynamic phenotype and can complicate the picture considerably. In addition, apart from lung parenchymal disease, you can also have increased pulmonary vascular tone in sepsis, so an acute pulmonary hypertension. This is not PPHN. This is acute pulmonary hypertension related to release of potent vasoactive molecules in the lung that can cause really profound pulmonary arterial vasoconstriction. This is another area where echo can help delineate whether pulmonary hypertension is playing a role in the clinical phenotype of oxygenation failure, and can provide further guidance in decision-making for choosing cardioactive medications. The kidneys also play a really big role in the hemodynamic phenotype, often as a consequence actually of hemodynamic dysfunction. The kidneys are quick to lose or have impaired autoregulation in sepsis for multiple reasons, and they can have direct destruction of the actual glomeruli related to either the inflammatory response or any endotoxin that the pathogen may cause. So as a result, that fluid balance, whatever fluid boluses and maintenance TFI that you're giving, and all of that needs to be considered, because if you have acute kidney injury and you have resultant fluid overload, that will change your cardiovascular mechanics, your lung mechanics. It will cause ascites, which makes it more difficult to ventilate the baby. It'll cause pulmonary edema, which also will make it more difficult to oxygenate and ventilate the baby. So this is a really important consideration of being very mindful of kidneys as an end organ, and looking at end organ dysfunction. And we look at urine output very frequently in sepsis to monitor this, because it does seem like kidneys are particularly sensitive, or are one of the first organs to display organ dysfunction. So just as a clinical tip, don't just use the 8-hour averaged urine output, because you might actually miss the trending down of diapers that the nurse is documenting. So a 20 diaper 8 hours ago and a 2 cc diaper 2 hours ago may still average out to be a 2.8 mils per kilo per hour of urine output, but you're actually missing that downward trend of urine output, which is reflecting impending renal dysfunction. And the serum creatinine tends to lag behind the urine output. So if you're just only monitoring the serum creatinine, you might miss, it might be normal even when the child has actually developed oliguria or anuria. So let's go back to our case to finish this up. This is what we had seen earlier. The child was tachycardic and hypotensive. We talked about tachycardia being a compensatory response in a low SVR state. We talked about diastolic hypotension, often preceding systolic hypotension in a low SVR state, until the heart can no longer basically maintain cardiac output. So that is what we're seeing here. The kidneys so far seem to be okay. Everything else seems to be okay. This certainly needs to be fixed, but in the absence of any intervention with picking up on these signs, we've seen that everything has gotten worse. The child's more tachycardic, profoundly tachycardic, and both probably the tachycardia, and there's probably an element of there's certainly profound low SVR state, but potentially some cardiac dysfunction going on that's now really dropped the systolic blood pressure in addition to the diastolic blood pressure. And then now we see the kidneys are impacted, the urine output has dropped considerably. So between here and here, there was opportunity, actually right after seeing this, there's opportunities to intervene with the therapies that we talked about earlier between fluids and vasopressor therapy. So overall, when we have a patient with sepsis, and hopefully very few progress to septic shock, but for every one of them, they're a high-risk infant. So we have to think about these 4 things. So early recognition, so really monitoring these kids after you've decided that they're getting a septic workup, they become a high-risk kid. So monitoring for progression into more severe disease. Source control, so appropriate antibiotics, consideration of removing a central line if you have to. Goal-directed therapy, so being quick to provide the fluids and vasoactive medications as needed. And that will be driven by the hemodynamic phenotype that hopefully you're identifying by frequent reevaluations at the bedside and the use of additional tools like echo. There's still a lot of knowledge gaps. Honestly, even the definition of sepsis and septic shock in preterms, the terms of infection, sepsis, septic shock seem to be not well defined in our population. We don't have a lot of great biomarkers for early detection, and certainly even less for septic shock. What type of fluid, how much, which is our first line vasopressor therapy. Hopefully we can answer that question soon. And then what happens to the kids after you get over this acute hump, after they have stabilized and hopefully survived their septic shock period? They often are quite edematous and they have a whole other host of complications to manage. So how we can best sort them out after in their recovery phase. In summary, the sepsis is a very complex illness that has to do a lot with what bug is the underlying pathogen, how premature the baby is, what their pro-inflammatory response is, what their anti-inflammatory response is, and what their compensatory mechanisms are. So that each baby is highly variable in our world, which is why we have to be very prudent about assessing the hemodynamic phenotype clinically and with echo if needed. And there's a lot of opportunities to study sepsis further. So more to come, hopefully, to answer these questions. Thank you.
Hello, everyone. Thank you so much for joining us here today. And thank you for Dr. Kharrat for your excellent presentation. As Patrick mentioned, I have the pleasure of introducing our panelists today. And at this point, I'd like to invite the panelists to please join on video so that we can ultimately have a great discussion. Our first panelist is Dr. Atreya. He is an assistant professor and pediatric intensivist at Cincinnati Children's Hospital. His research focus is on understanding the role of PCSK9 in pediatric septic shock. He has received recognition for his work in the field by the Society of Pediatric Research, and he is currently working on marine models of sepsis to validate his clinical findings and to identify the biological pathways involved. Our second panelist is Dr. Bermick. She is an associate professor and neonatologist at the University of Iowa Stead Family Children's Hospital. She runs a basic science laboratory that focuses on understanding how the neonatal immune system develops under normal and inflammatory conditions. And this includes the study of fetal and neonatal immune responses during chorioamnionitis and neonatal sepsis, with the goal of identifying therapies that can mitigate the morbidities and mortalities associated with these early inflammatory conditions. Lastly, and not least, Dr. Willem de Boode is a professor of neonatology at Radboud Amalia Children's Hospital. He is the coordinator of the Neonatal Hemodynamics Research and Training Center there, and has recently been appointed the president of the European Society for Pediatric Research. He is additionally a project leader on the Benedictus trial, which is an international multi-center randomized controlled trial. And just with that, a little reminder to please direct your questions into the chat. And then I will kickstart our question session. And the first question is for Dr. Kharrat. Does warm shock always precede cold shock, or does it differ based on phenotype?
Warm shock does not always precede cold shock. Either can come before the other, and children can present only in one type of picture. So it really depends on the relative balance of all the various molecular things going on between inflammatory response, release of vasoactive substances, catecholamine response, adrenal response. So that balance, like we talked about, is dynamic, and there is not necessarily one that precedes the other.
So Ashraf, fantastic talk. So I want to just take things off on a slight tangent at the moment and invite Dr. Atreya in. So thank you so much for joining us today. We're always delighted to have our colleagues from the PICU world. So one of the things you probably have picked up on, and you probably may remember, is that in the NICU, we don't have very much available to help us differentiate when patients oftentimes get sick from a cardiovascular perspective, and then identifying, not just early shock, but actually, do you have shock or do you have sepsis-related shock? I would love to hear a little bit about, in the year 2023, in the modern PICU, okay? How do you guys, what is your level of monitoring? What do you use? What's the gold standard for determining septic shock in the PICU? And with that said, kind of where are you guys with the approach to defined septic shock broadly? And you can speak to either cold or warm shock, or do you even use those terminologies in the year 2023?
Yeah,
a fairly broad question, but
yes,
just welcome us into your world as briefly and economically as you can.
Yes. First of all, thank you to yourself and Dr. Vasquez for the invitation. And there was a really outstanding overview of hemodynamic assessment and neonatal sepsis by Dr. Kharrat. I will say that I was surprised in the sense that the vast majority of what was described was not very dissimilar from what we practice at the bedside in the pediatric intensive care unit here at a large quaternary center. So I would say that much of the diagnostic criteria for sepsis and septic shock is defined based on consensus criteria, and the PEDS world has not moved away from the syndromic definitions and has not really aligned itself with the adult definitions, which are based on the SOFA scores and QSOFA scores. So I will say that not too much is different in that sense, but some particular nuances would be that, I think I couldn't stress enough assessment and reassessment as was outlined. I do think at the bedside that we are looking at cold shock and warm shock as certainly things that we assess, and make treatment decisions based off of in terms of which vasoactive support to use beyond your initial fluid resuscitation. So a patient with warm shock, we'd consider norepinephrine, as was described. The patient with cold shock, we would typically start with epinephrine and calcium in addition to vasoactive support, and perhaps milrinone as an for its inotropic vasodilatory properties as well as lucitropic effects. With that, I would say use of milrinone is probably a highly selective population where we have echo data, which is corroborative, and then the patient has to have an absence of kidney dysfunction or acute kidney injury. We wouldn't certainly want milrinone to accumulate in the system. So I would say that one thing, which again is not systematically implemented, is certainly echo to help guide sort of ongoing management of patients. Typically, it's a one-time echo, but if a patient has persistent need for vasoactive support, we are considering getting repeat echoes. And then where available, I think we will use non-invasive approaches to measure mixed venous oxygen saturations. So we wouldn't use NIRS, but something like a T-stat machine, and where available, we'll have an upper extremity central line, either through the neck or a PICC line. We're trying to trend mixed venous saturations centrally. Again, I would reemphasize the fact that trends matter much more than static assessments. And I would assume that's the same in your world, but really not much is different. I think there's some we have the benefit of some additional studies and some additional in terms of choice of fluids and so on, but I'm happy to discuss that as a group.
Wonderful. We'll just slightly change the order for a second, because I want to build off this and take it to Willem. Okay, who's a lot of expertise in multimodal monitoring, is very interested in tissue oxygenation and shock, etc. And Willem, if I had to put you on the stage, you know, how can we do better at monitoring these patients? You know, is there a role for more CVP monitoring? Should we be thinking about this earlier? And then secondly, there were a number of questions that came through the chat on the specifics of echo itself. So obviously many of us will kind of do very comprehensive echoes following cardiac output, et cetera, but the one thing that always is pushed when people ask us about, is the patient hypovolemic on echo? And I would be curious to get your thoughts on how do we enhance monitoring and the value of echo in actually particularly the hypovolemia element to this.
Yeah, thank you for this question. First of all, I would like to compliment Dr. Kharrat for an excellent overview, very comprehensive overview on the neonatal shock. I thank you for that. And one of the things that Dr. Kharrat said, the importance of frequent re-evaluations, and that's the big question. How are we going to frequently re-evaluate the status of the circulatory situation of the infant? I heard three questions. The first was about central venous pressure and also the hypovolemia. We stopped using the central venous pressure because in the neonatology, it's not that easy to get the central line. And if you're lucky, you've got an umbilical venous line. But mostly that's also used for a lot of medication. That makes it very difficult to get a reliable measurement of the central venous pressure and the central venous curve. That impedes the correct interpretation in my perception of the central venous pressure. Moreover, it's very much influenced by our ventilator settings, the mean airway pressure. So that makes it always very difficult to solely trust the central venous pressure. That brings us to the neonatologist performed echocardiography, the TN echo, and trying to evaluate, is there hypovolemia or not? Personally, I find that the most difficult and most tricky part of echocardiography. I don't trust myself. I don't trust anyone in telling me that based on the echo, I'm sure the baby is hypovolemic. I think when it's very, very at the end of the spectrum, it's obvious. You see the kissing ventricles and a collapsing IVC. Probably you're right, and you could use that to give a fluid bolus. However, the collapsibility of the inferior vena cava, it's so difficult. It's also related to the ventilatory settings, the ventilatory status of the patient. So to be honest, I think it's hardly possible to have a correct interpretation of the volume status based on echocardiography. Is that an answer to your question?
Yeah, no. I think what I wanted to do, I think the message I want to say to people is it is hard. Certainly in our hands, the situation whereby you have a collapsed IVC and an empty heart with flow acceleration and your outputs are all low, if everything is all going in the same direction, then you might suspect you give volume and then you get a change that's benefit. With the retrospectoscope, you can say benefit. But yeah, I think that's the message that I wanted to get across. Thank you, Willem.
Switching gears a little bit, this question is for Dr. Bermick. In clinical practice, we sometimes find ourselves faced with septic babies who experience a profound state of inflammation and immune dysregulation. Oftentimes, clinically, we see severe anasarca. Do you have any recommendations on how we might approach those patients in our clinical practice?
Did you plant that, Patrick?
Yes, of course.
Yeah, okay.
Why do you think I brought you here today?
So thank you, Angelica, for that very thoughtfully worded question. I think we've all seen patients with anasarca following an acute inflammatory infectious event. And we actually at Iowa have dubbed it neonatal capillary leak syndrome, which is not a described entity elsewhere that we're trying to publish. And we've come up with a protocol for how to manage these babies. And from before we implemented our protocol to after, our mortality went from 100% to 20%. So we've been very good at managing these babies. And a few special things about them is the babies we particularly focus on are under 26 weeks gestation. Their immune system and their endothelium just seems to be very different, as Dr. Kharrat was talking about the endothelial damage and preterm infant endothelium being more susceptible to inflammation. And so what we thought we'd find when we first started looking at these babies is that they would have a large inflammatory event and then their inflammation would remain throughout the entire course of their anasarca. What we actually found when we did cytokine profiling in my lab is that they had a large peak of inflammation around the time of whatever stimulating event, necrotizing enterocolitis, sepsis, that then the inflammation resolved by about 3 to 4 days before they actually became grossly anasarchic. And then they were not inflamed during the remainder of the time that they were fluid overloaded and leaky. So what we think is happening is that the high level of inflammation damages the endothelium, and it's that persistent endothelial leakiness that's causing the problem, not the persistent inflammation. So our approach to manage these babies is to fluid and volume resuscitate them. We give them a lot of fluid and a lot of colloid containing fluid, blood products whenever indicated. We also will do albumin. We support their blood pressure with whatever kind of appropriate support based on their hemodynamic status. But then we have several therapies that we use to actually tighten up the vascular endothelium. So we use high dose methylprednisone, and we use it actually pretty quickly. We do that for a minimum of 5 days, sometimes extending it longer. We do high dose IVIG, so 1 gram per kilo. We usually will do that daily for about 5 days. And we use theophylline, and we aim for a level of 15 to 20. All of those act to help tighten up those endothelial junctions and decrease the capillary leak. And then once the endothelium gets better, they're able to kind of diurese themselves, and we help them sometimes. to get them back to baseline. But we've had a massive improvement in their survival with this approach. And really, we think, even though the general thought is that the preterm and neonatal immune system is immature, it's just dysregulated. And so it's this hyperinflammation in these really small babies and the lack of ability to kind of do the anti-inflammatory counter-regulation. That's the problem that we see.
Wonderful. Jenny, can I just ask you, viral versus bacterial in terms of capillary leak? Has anyone looked at that, or any preliminary thoughts on that? Should we suspect that there might be a difference in post-viral versus post-bacterial?
Probably the end result is probably similar. I think what is going to differ is the type of viral infection and how long it lasts. I know kind of why you're asking. If it's an acute viral illness like rhinoenterovirus, RSV, influenza, I think the course will probably be similar to the bacterial. It'll resolve relatively quickly and the inflammation will go away. If you have something that's going to be a little more persistent, say a bad CMV infection or HSV, I think you might have more persistent inflammation and you might have to tailor the approach that way.
Wonderful. So Ashraf, can I take you back to something that's a little controversial? Sorry, I live in the land of controversy all the time. But sepsis and pulmonary hypertension. Okay. And first, maybe can you comment on making that diagnosis? Because one of the things that you commonly see in septic babies is that their PDA is open, but when they become very hypotensive, you may have a right to left ductal shunt. Okay. So, and that would be important because, certainly in my experience over time, I've seen babies being treated with nitric oxide for right to left ductal shunts who are not necessarily in hypoxemic respiratory failure. So maybe comment a little bit about that. And then the second part is, how might you modify your choice of vasopressors if you have pulmonary hypertension with septic shock? Because the response certainly on the systemic and pulmonary vascular bed sometimes is different.
This is a great question, and this is something we see clinically in those really sick babies, at least the hypoxic respiratory failure piece. So as we talked about, hypoxemia is multifactorial, and we can think of it from the lung level, pulmonary parenchymal, pulmonary vascular disease, cardiac function, and then vascular, and then oxygen delivery from red blood cells. And so you can work through all of those different things to think about what I need to address when I have a child with hypoxemia. But from a pulmonary hypertension perspective, well, there's certainly a pathophysiological possibility for why these children will have acute pulmonary hypertension based on release of significant release of pulmonary vasoconstrictors. What's interesting from an echo perspective is they can be hard to identify or clearly delineate on echo. Often you won't see if we think about like our classic echo identifiers or features of pulmonary hypertension, TR-jet, for example, you may not see if you have cardiac dysfunction for whatever reason, because of your underlying, your initial sepsis response or your direct myocardial impact from the sepsis pathogen. You can get cardiac dysfunction from that. So you're unable to actually generate a TR-jet. You'll get, as you mentioned, Patrick, you can use your shunts don't diagnose pulmonary hypertension. They basically give you a reflection of PVR to SVR state. And so when you have profoundly low SVR state, and even a normal PVR state, you can still see a right to left shunt through a duct. And so just calling it a right to left shunt does not really mean that the child has acute pulmonary hypertension. Then we'll also look at markers of pulmonary blood flow. So look at our pulmonary vein Doppler, for example, and see what's actually the blood coming back to the left side of the heart in the context of a child with significant hypoxemic respiratory failure. So there's a biological possibility for sure for acute pulmonary hypertension. There are echo ways to identify these kids, although it's trickier than identifying it pulmonary hypertension than in a normal SVR state. So like regular PPHN with nothing else going on. Well, what seems to be interesting is a couple of things. We presented this at PAS last year, is that these children with hypoxemic respiratory failure actually don't seem to have markers of pulmonary hypertension, but more seem to have markers of LV dysfunction. So that it might be an oxygen delivery, cardiac output oxygen delivery that's driving that. And the second thing is anecdotally, and there's some little pieces from other nitric or HRF studies that seem to show that children with neonates with late onset sepsis tend not to be nitric responders. So we'll often, the clinical team will often initiate inhaled nitric oxide on these patients because it's something you do for a child in 100% oxygen, but they just don't have that beautiful, profound response that, like the 1 hour-old PPHN kid will have, will they go from 100% to 25% in half an hour. So this can tell us basically one of two things. Either there's a different underlying pathomechanism going on from the pulmonary vascular perspective, or, and probably the or is a big thing, is that this is their HRF and sepsis is multifactorial. It is not an isolated pulmonary vascular disease problem. That's probably some of the problem, but then you have to think about all those different areas where oxygen can travel, like I talked about initially, and address all of those different components to address the HRF.
My next question is for Dr. Atreya. There's a couple of inquiries about ideal timing of when to initiate steroids, basically who and when, in terms of your sort of mental algorithm when approaching these patients.
This is a very interesting question because in the pediatric world, non-neonatal world, there is actually great equipoise in terms of use of corticosteroids in septic shock. So I'm actually curious to hear the opinions of other panelists on this front. So we have a multi-center, multinational randomized trial of stress dose hydrocortisone, which is ongoing in children with septic shock. And I believe, they've enrolled about couple hundred patients, but the challenge is that while there's a subset of patients who may improve from corticosteroids, is because of the wide-ranging effects of steroids on the immune response, patients who have a repressed adaptive immune system are have been seen to have a worse mortality and risk of organ dysfunction. So I don't know. I mean, before the trial, we would give it on any patient requiring 2 vasoactive agents. But I think there's equipoise, and I'm curious to hear what others have to say. Because again, there's certainly a subset of patients where it's potentiating the adrenergic effects of vasoactive agents, but because of the immune consequences of corticosteroids, we don't know.
What do you think, Ashraf, Willem, Jenny?
So I think this is such an interesting topic in sepsis. It seems that a lot of units will use corticosteroids on spec with basically the thought that preterm neonates already have relative or absolute adrenal insufficiency. They're quick to deplete their endogenous steroids. It's hard for them to replete it. So often we'll use it as some units use first line, but I think more commonly a second line or adjunct agent. And cortisol is using cortisol to drive that is a very interesting or controversial thing, because your cortisol is a one-time snapshot reflection of who you are and what you have, and doesn't reflect what's going to happen the next 6 hours or 12 hours, 24. And then there are, for many logistical reasons, it's hard to get an ACTH stim test in acute time. I would be surprised if some units did that acutely. So I think there's, again, a physiologic rationale to use steroids. Now, we don't have really any actual prospective studies in neonatal sepsis looking at steroids. This is something that is an area that we're looking at, because there's a lot of potential here to explore the utility of steroids. We have modeled some of our understanding based off of pediatric literature, and in Canada there is a group of investigators that's driven by one pediatric intensivist in Ottawa, Kusum Menon, who she's currently running the SHIPS trial, which is looking at steroids in pediatric sepsis. So there's some upcoming literature from pediatrics. I hear there's the same equipoise. I think it exists the same in neonates, but I think many neonatologists will use it. Will use steroids in sepsis. The one thing is we don't have a dosing that we all agree on. We don't have a timing, like, do you initiate it first line, second line? What is second line? What is catecholamiine refractory? And how do you taper? When do you taper? All those questions are probably highly variable.
Before Jenny and Willem answer, I just want to make sure that we're speaking in the context of the acute, not the capillary leak type of use of steroid. And I'd also like people to think about it from the perspective of, when you are inotrope refractory, okay, the assumption that maybe you need hydrocortisone to enhance sensitivity, but also the concept that the drug that you gave was the wrong drug, or actually maybe causing harm, because oftentimes when babies are refractory and getting sicker, we assume that it's the baby getting sicker, but actually maybe the drugs themselves may be causing harm. So just to add that to make the conversation more provocative. So whichever you want to go first.
If I may start, I fully agree, as already mentioned by Dr. Kharrat. Personally, I start the steroids with when the first line of vasopressor in a warp shock doesn't give you the initial response as you wish to had, and then because also there's a disbalance in your pro and anti-inflammatory substances, and my hope is that the steroids will have an influence on the pro-inflammatory response. So that's why I choose for hydrocortisone. But fully, I understand and I agree with Patrick that when the course of the baby is not in line with your hypothesis, you should reassess and try to see, is my hypothesis still right? Did I have a good pathophysiologic explanation for this situation in the baby, or did I misjudge, and should I reconsider and probably use another cardiovascular drug or cardiovascular approach in this specific baby?
And my personal preference is I go to steroids, hydrocortisone in particular, early in suspected sepsis, probably similar to the time I'm having to start a blood pressure supporting agent. Primarily because, especially in preterm neonates, they essentially have relative adrenal insufficiency, and rarely are you going to get them out of an acute septic episode without steroids. We worry a little bit less about the off-target immune effects, just because particularly the adaptive immune system in preterm infants does not function appropriately. It is not going to function whether you give them steroids or not to prevent secondary infections later on. So that's not really a consideration I take into account when I'm using it. And then what they have as far as their immune system isn't able to clear any of the organisms effectively anyway. And so I don't really worry about any of the acute kind of immunosuppressive events or effects of steroids. I more want to get them to survive the episode and deal with the rest of it later, which I think steroids are pretty effective at doing.
So Jenny, you'd probably knock my head off after for the questions I'm going to ask you, but that's okay. We're all friends here. Part of the more so one of the questions here, and I'm not surprised this question was asked, was the use of albumin. Okay, and again, a very controversial topic, particularly in the setting of capillary leak. And I think there's two parts to the question. One is what type of albumin, okay, and what threshold. And then the second part of the question is your protocol. So you have 3 different agents. Why do you need all 3? Which of them is more important or less important? Do we have any sense of that? And how do we come up with that kind of multifaceted approach to this entity, and can it be further refined?
Yeah. To tackle the albumin question first, I don't have a hard and fast cutoff. I kind of look at the patient. I'll let a patient sit with an albumin below 2.5 if they're not worsening, if they are not needing blood pressure support, if they're not continuing to become more and more edematous. If I have a patient with acute capillary leak syndrome, I try to give them 25% albumin to at least maintain them over 2.5, knowing that some of it's going to leak out, but if we can give them anything intravascular that might help them. I don't typically use 5% albumin for resuscitation. I don't think the data is great about supporting that. I prefer blood products. So if I think PRBCs or platelets or FFP would help, I prefer to give the volume that way, but I will do some 25% albumin in some cases. And then the IVIG question is a great one because it hasn't been effective in neonatal sepsis trials, either giving it prophylactically or giving it acutely. The reason that we use it is a little bit different than what they used in those trials. So we kind of based our protocol off of adult capillary leak syndrome, which is a genetic syndrome that causes a very similar phenotype and isn't always stimulated by an acute infection or inflammatory event. And they use high-dose steroids, IVIG, and sometimes we'll use theophylline effectively. And so we really use the IVIG in this situation more for the endothelial kind of restitution of the barrier function. Nobody really understands why it seems to work, but it does seem to work. We don't check levels and we don't aim for a certain level there. We just give a lot of it. It's unclear which part of our protocol is effective, but all three of them together seem to work really nicely. There probably is room to modify a little bit more. We did use some biologic anti-cytokine therapies sometimes, including infliximab, which targets TNF. The reason we don't routinely do that is the data I've got from these kids when they're acutely inflamed and then develop capillary leak is that they don't remain inflamed. So blocking more inflammation when it's not present in the bloodstream isn't helpful. And all of these pro-inflammatory cytokines are necessary for tissue healing, particularly TNF. And so if you have a baby who develops capillary leak syndrome following an intestinal perforation, the last thing you want to do is prevent appropriate healing of that bowel lesion. And so we try to stay away from the inflammatory or anti-inflammatories if possible. So I don't know, I think there is room to modify the protocol potentially, but this is really the first thing anyone's done in this arena. So I think just getting it out there is important to start.
And thank you. I just thought it was important just to put that into context. Just very quickly before we go on to the last question. Given the 25% albumin, if it doesn't go up or potentially goes down after the bolus, would that prevent you from giving it again?
No.
Yeah.
I expect it to go down. It's going to leak, but the last thing I want, I'm actually okay if it still remains kind of 1.8 or above. What I don't want is it to be 0.8, because that's just going to pull more stuff out. I think if you can, in the meantime, while you're trying to heal the endothelium, try to give a little bit of something to keep things intravascular. It can be helpful.
Okay. I think we have time maybe for one more question. This one is for Dr. Boode. There have been a couple of questions about your opinion on the utility of renal NIRS as an early hemodynamic marker of septic shock, and if the use of NIRS and fractional oxygen extraction can potentially be used to sort of help elucidate one of the two phenotypes that we sort of just heard earlier.
Thank you for this question. Well, I think one of the pivotal parts of management of septic shock is to have an early detection. In my understanding, NIRS won't give you an early warning signal. It's maybe the renal NIRS, the renal regional oxygen saturation can tell you something, but I'm not sure it will give you the exact figure. I'm in doubt whether an absolute value will give you information. The trend monitoring might give you information, but then still I'm concerned about the inaccuracy of the NIRS monitor. It can tell you a certain saturation, but it can be 8% higher or lower. So how to manage with that? I think we should try. I think the microcirculation, as already mentioned, is very important, but you also have to look at the macrocirculation, try to prevent that the microcirculation in a later phase will be also damaged and will be involved. So I believe we should focus on blood pressure together with blood flow measurements. And I think in that situation, you can detect very early a shock, and you can also delineate what's the underlying pathophysiology. Is it an increase in systemic vascular resistance or a decrease in systemic vascular resistance? And that probably will be more helpful.
Okay, wonderful. So it's 2:15 Central Time. I want to call this to a halt. This was an absolutely astounding presentation, panel discussion today. I have attended and given talks at a lot of webinars in conferences. I have never seen so many questions, okay, in any webinar ever. So that's a huge credit to the topic, the speaker, the panelists. This certainly augurs well for the 2024 Hemodynamics Club. So Dr. Kharrat and Dr. Boode will be our speakers in Toronto next year. So we look further for more lively debate on this topic. Thank you all. Thank you, Angelica, for co-moderating. It's been a pleasure with you. And thanks to everyone that joined today. If we didn't get to your question, we apologize. We will kind of provide a list of these questions to the speakers, and they hopefully will be able to get a chance to respond to you directly. So thank you all. Have a wonderful day and the rest of your week.
Thank you.
Bye. Thank you.